Good afternoon on this beautiful fall day. I want to welcome you to Bioethics Grand Rounds. My name is Grace Wee. I'm the director for the Center for Christian Bioethics. It's my privilege today to extend a warm welcome to Bioethics Grand Rounds and our session on addressing addiction, stigma, and healthcare. Bioethics Grand Rounds serves as a forum for robust discussion and critical examination, and we also hope it serves as a place to share insights that will guide us in navigating these ethical waters. Our collective wisdom and our dedication to ethical considerations are key to ensuring that while we are progressing in medicine and biotechnology, our progress aligns with the teaching and healing ministry of Jesus Christ. So thank you for being part of this vital conversation today. And I really feel like that our topic is particularly relevant because addiction in all of its forms presents a unique set of ethical challenges. From provision of care and support to the topic of our conversation today, societal stigmatization in healthcare. I'm really grateful to our speakers today for his conversation. And before I turn it over to Dr. Yishan Ma, I do want to make a couple of housekeeping announcements. This will be recorded and will be up on our website next week. For those of you who want to sign in for CME credit, please don't forget to scan the QR code and to fill out the form for your CME credit. And a couple of upcoming events. On March 1st, 2024, we have our Provantia lecture. That's at 9 a.m. That's followed by our symposium on professional formation. But our Provantia lecture this coming year is Dr. Benjamin Doolittle from Yale University. I think you'll find his lecture provocative. And also from May 5 through 7, we have our Adventist Bioethics Consortium Conference at Kettering Health Network. And now I will turn it over to Dr. Yishan Ma, who is our assistant professor at the School of Religion. He earned his PhD from Claremont Graduate University and also is finishing up his MSW degree at our School of Behavioral Health here at Loma Linda. And in addition to all of his other duties, he's an associate director with the Center for Christian Bioethics. So thank you, Dr. Ma. Please welcome Dr. Ma.
Thank you so much, Dr. Wee. Again, I want to warmly welcome all of you who are joining us in person as well as, excuse me, welcome you. Either you're joining us here in person or online. Today we have 3 learning objectives. The first is to explore different kinds of stigma patients with substance use disorders might experience. The second one is to learn how stigma impacts the clinician-patient relationship in healthcare settings. And then the third is to learn practical ways to address stigmatizing attitudes and experiences. So the focus of today's conversation is going to be on caregiver stigma, meaning that we're talking about how caregivers, people who care for those who may be experiencing a substance use disorder, may acquire stigmatizing attitudes over time. So I'm really very much looking forward to today's conversation. Before we begin, I would like to introduce our 2 esteemed panelists who is going to be engaged in a conversation with one another about this important topic. Dr. George Christison. After completing a residency at Duke University and a schizophrenia research fellowship at an NIMH, Dr. Christison joined the Loma Linda faculty in 1988 and is a clinical professor of psychiatry. His academic activities have included extensive medical student teaching, as well as research on attitude towards persons with psychiatric and substance use disorders. Clinically, his focus has been on caring for the seriously mentally ill in public sector settings, including San Bernardino and Riverside counties, the VA hospital, Patton State Hospital, and the California prisons. Pertinent to this seminar, for 4 years, he was one of 2 psychiatrists caring for the psychiatric needs of persons enrolled in Cedar House, San Bernardino County's drug and alcohol rehabilitation facility. So thank you so much, Dr. Christison, for joining us. Second panelist, Mr. Randall Walker. Mr. Walker is an assistant professor at Loma Linda University in the School of Behavioral Health's Department of Counseling and Family Sciences. Currently, he's the interim director of the Counseling Master's Program and interim director of the School of Counseling Certificate Program, and the co-director of the dual degree master's degree. And since 2002, Mr. Walker has served as director of the Drug and Alcohol Counseling Certificate, which he helped develop for the CFS department here at Loma Linda. Mr. Walker is also a licensed marriage and family therapist in private practice in Upland, California. His practice focuses on working with adults and families dealing with addictions and recovery. He has supervised pre-licensed therapists in a variety of settings, starting with Matrix Institute and Addictions and continuing most recently at Gibson House VARP in San Bernardino. He made it his life's mission to support and behavioral health providers to better understand, recognize, and engage and motivate and retain individuals and families living with substance use disorders and treatment until they are able to make meaningful changes in their lives. Needless to say, we have two panelists who are more than qualified to teach us about this important topic today. And so I now turn the time over to Dr. Christison, who will begin us with the conversation with vignettes.
I'm still waiting for my growth spurt, but I wanted to start with just some slides to sort of set the table for the conversation. And so this is our topic. In terms of disclosures, we have no conflicts to disclose. Actually, I have lots of conflicts, just not financial ones. So the first question really that we want to ask is, for today's purposes, what do we mean by stigma? And a picture is sometimes worth 1,000 words. And so this is a picture of, and don't tell me you haven't ever felt this way when you saw the next name on your appointment list. Now, if this doctor knew the patient and has had an ongoing relationship with the patient who's difficult and just has that reaction, we call that negative countertransference. However, if she's having that reaction simply on the basis of seeing that her new patient has substance use issues and knows nothing else about them other than the category, that's stigma. And so really the first question is there stigma? Is there evidence that caregivers view patients with substance use disorders more negatively than they view patients with other disorders? Now, in order to answer a question like that, you need an instrument that measures attitudes for more than one condition, so that you can measure the attitude toward condition of interest, substance use, and a control condition, because they may have low scores on the condition of interest simply because they're grumpy that day and would have low scores toward anything. So 20 years ago, no such scale really existed, and we wanted to do some medical student research on these kinds of things. So along with two really smart psychologist statisticians, we developed what we call the medical condition regard scale. It's just 11 items, single factor. But three themes really, and it's just, it measures to what degree respondents find patients with a given medical condition, anything you want to put in the blank, to be enjoyable, to be treatable, and to be deemed worthy of medical resources. And the scale's actually proven to be quite useful. It's been used around the world. It's been translated most recently into Farsi and Japanese. The majority, interestingly, of studies using the scale have looked at substance use compared to other conditions. And the largest such study that I know of is this one, and that's the one I wanted to, this is the only data we're going to show, but I think it gets the point across. So this is actually a huge study across 8 different countries, and 866 clinicians of various disciplines working in different settings. And they asked, they measured the regard for patients with alcohol use problems, with patients with substance use and drug problems, patients with depression, and patients with diabetes to compare. And the green bar is the total, but that includes people who are psychiatrists and actually people who've chosen to work with substance use disorder patients. So I pulled out the primary care physicians and other caregivers in primary care. And on this scale, 5-point difference is probably meaningful. So look at how primary care physicians rated their regard for patients with diabetes. It's a 52 compared to substance use, 38. I mean, that's a huge difference. And all they knew about the patient was that they had that diagnosis. And they already had this regard. So it's pretty clear. And the other studies that were smaller that looked at the same thing using the scale and in other ways have found pretty much the same pattern. So yeah, there is stigma in the sense of a negative perception of a category of people before you even meet them. Now, in order to kind of grease the wheels and set the table for talking about this, I wanted to give some vignettes from my own clinical experience, and then we can move on from there. So these are, so I'm just going to run through these. These are very short, but I think it captures what I was trying to capture is kind of somewhat of the lived experience of the caregiver and the lived experience of the person with the substance use disorder. So here we have a 34-year-old man recently weaned off long-term benzodiazepine misuse, and he has a positive UDS for benzodiazepine. When presented with a result, he states, "Oh, a couple days ago, I spotted a pill on the floor, and I thought it was my blood pressure medicine, so I took it. It must have been an old Ativan." I had to hold really hard on my mouth to not make any snarky comment, but yeah, this is an actual case. Another case, and this guy was a sweet guy, a 20-year-old son of a pastor steals his mother's wedding ring, steals his brother's prized shotgun to pawn for money for opiates. Another, a 43-year-old woman with no history of benzodiazepine use requests from her PCP some short-term benzodiazepine treatment while she's awaiting to get into therapy. Now, the patient was widowed 2 months earlier, has 2 young boys, and is in the midst of an ultimately successful sexual harassment suit against a really terrible boss. The PCP denies the request, saying, "The last time I did this, the patient was lying and manipulating me. That's not going to happen again." In an ED that had patient rooms, this is a long time ago, a young adult patient is curled in a fetal position facing the wall with his face in his hands. When we walked in the room, it had a strong solvent smell, and the patient was found to be actively huffing in the emergency department. He couldn't put it down. 25-year-old former Marine had a dishonorable discharge, a divorce, and lost access to his children, all due to his opioid use disorder. 3 weeks into rehab, he says with a haunted look, "It's always calling to me, doc, always calling." A week later, he leaves rehab and is lost to follow-up. This guy was just a sweetheart. I mean, he a very genuine, honest, sincere guy, and I don't know what happened to him. 28-year-old dual diagnosis patient with depression and methamphetamine use disorder completed residential rehab 2 weeks ago, presents for depression follow-up. He's sweating excessively, speaking rapidly, is unusually irritable, and can't sit still. He denies any recent use, but refuses a drug screen and leaves abruptly. Last one, 37-year-old former businessman enters county rehab for the 4th time. He's destitute. His family refuses to have anything to do with him. 12 months later, he remains in recovery, attends 4 to 5 meetings per week, has a job, and is beginning to reestablish family relationships. Okay.
Thank you so much, Dr. Christison, for that really excellent introduction to today's conversation. So I'll be here trying to moderate the discussion, and we're going to leave plenty of room towards the end of the presentation for question and answers or question and response. I will be monitoring the online chat as well. If you're here attending in person, raise your hand and we will have somebody run the microphone up to you if you want to ask a question or engage in a conversation with our panelists today. If you're joining us online, which I'm happy to see there are quite a few of you online, please type your question into the chat box and I'll be here monitoring the chat and then I'll read those questions to our panelists, okay? All right, so as we are listening to these vignettes, right? No doubt, it doesn't matter if you are a clinician who has encountered or is participating in the treatment of people with substance use disorders, or just somebody in the community, right, who know people who are struggling with addiction. No doubt they evoke a mixture of emotions, thoughts, and attitudes. Can you tell us a little bit about, what sorts of emotions, thoughts, or attitude constitute stigma, or what's stigmatizing all about?
Yeah. Maybe I'll start off. Am I audible to everybody, I guess? So I think one of the first thing that comes to my mind, and your excellent vignettes kind of trigger that for me, is I think as a clinician, as a professional, often there's this sense that I don't want to be had, so to speak. So someone comes in and they are, for instance, the vignette about the physician being asked to prescribe on a short-term basis a medication that would maybe help the patient, but the physician doesn't want to be cheated or made to look foolish because they prescribed something that ended up being abused. I think that's a really common sort of response. And often it maybe causes us as professionals to maybe put up a wall that's an unnecessary wall or create an obstacle. I think about I haven't worked a lot with opioid users in my clinical practice because I spent a lot of time working with stimulant users. But I know the opioid users that I've met who would ask for like money for gas or something like that to get to the treatment center. There was, I had to check my attitude that, well, wait a minute, are they going to really buy gas with this, or are they going to go out and buy drugs with it? And so there's that sense of not wanting to be taken advantage of and not wanting to look foolish. I think that plays a big role in that stigma. And maybe in a sense, there's a sense of professional shame in the sense that, okay, I'm going to look like an incompetent professional if I kind of go beyond a certain boundary perhaps and help this person, or extend my boundary to help this person, and then it turns out they were lying to me or they were misrepresenting their need.
Yeah, I think that we all like to have easy days, where you just kind of go through and you can just do your regular stuff and it all works out fine. I think part of the very basic aspect of the stigma of people with substance use disorder is they are not easy patients, and not in a sense their fault, but it's complex. And you have to kind of gird up your loins and realize this is going to be a journey. This isn't going to be something I can just take away with a nice prescription, and a journey in terms of both treatment, but also relationship building, because you don't know when they're lying to you. Well, sometimes when they say they pick up a pill off the floor, but other times, it's hard. And to just be able to come to a place where you say, that's part of the condition, I accept that, I'm going to be lied to at times, I'm going to be manipulated at times. And, in a sense, that's the muddy middle that we end up with in a lot of places. I mean, at the one end, thankfully, there's not too many docs that do this. There's the candy man who just hands out everything because he's not willing to be discerning. On the other side is the person who just says, no, I'm not going to deal with it. But in the middle is where it's hard. And I think it's, in addition to that sense of being lied to or manipulated, it can be sad and frustrating. So that, I think, is part of what contributes to the stigma.
And I'm just hearing you talk I think I would also add to it, I don't know so much from a psychiatrist's point of view, but I know from a typical MFT's point of view, a master's level clinician, most of our caseloads don't involve mortality or death unless we're working with, certain kinds of diagnoses. But I know as someone who's spent a long time working in the substance use disorder treatment field, I've known a lot of people who have died and as a result of their addictions. And that always, I think, kind of contributes to the stigma. There's that fear, I think, that, if I do something wrong, am I the last contact this person has in his lifetime? Because if I do, I have colleagues who they are real clear that they got into recovery because somebody basically did the tough love approach with them and told them, don't come back until you're sober for 6 months. And it worked for them. But I'm sure between the two of us, we know lots of people who that didn't work well for, and they ended up dead. And that figures in a stigma too, is this thought that, when I do couples counseling, is as painful as marriage sometimes is, and a blessing at the same time. I don't think a whole lot of people die from marriage. But people do die from substance use disorders all the time, and at alarming numbers.
Yeah, and the flip side of that, and we'll talk about how to counter the tendency to stigmatize, is that if you've jumped into this pool and are working with patients who have these disorders, you have a chance to save a life. Mm-hmm. And if you work on your skills and do it well and use motivational interviewing and help them progress to where they're ready for rehab, you can save a life. Mm-hmm. And a family and others. So it is one of those high reward and high grief kinds of populations.
So in healthcare context, one of the models that we, broadly speaking, works on is the assumption that addiction is a kind of brain disease, mm-hmm. right? And we know that this model is relatively recent. It's not the newest thing, but it tends to frame a lot of discussions among healthcare professionals about the nature of addiction. How has that impacted your clinical context, right? How has that helped to address some of the stigmatizing attitudes? Has it been effective in doing so? How does it work in your own clinical experience?
Yes. Well, one of the reasons I got into psychiatry is because the brain fascinates me. So the notion of accepting it as a brain disorder is not tough. I mean, and there clearly are changes in the nigrostriatal dopamine system that happen with addiction that reinforce it and make it harder to get out of. I think that for physicians, in many ways, what makes a condition less stigmatizing is if a good treatment is found. Like, people don't want to deal with fibromyalgia because we don't have a good treatment yet. So they'll go so far as to say it doesn't even exist. So in that sense, it's still a very difficult condition to treat, substance use disorders, broadly speaking. We do have some medical treatments that have some impact, but I think for physicians, that's kind of more the fulcrum of is this easier to treat? Can I get successes with it? Or will I just have frustrations and failures more often? Now, when you move out to family and community, though, I think it's a very different calculus. I think it does help reduce stigma to be able to say it's not a character issue, it's not a personality issue, it's in a sense not their fault. But at the same time, you're balancing that against the pain. of having family members who are caught in addiction, who you do feel betrayed by, who have gone out and used when they promised they wouldn't, and so that even though you're knowing it's a brain issue, all the other stuff that comes with it can, I think, outweigh it and still be creating a pretty negative view.
Mm-hmm. Yeah, I would agree. I think, and I like how you are distinguishing between what healthcare professionals would maybe do and then what family members would do, because I think as a family therapist, that's often where I get a lot of pushback when you talk about substance use disorders being a brain disease, is the idea that because it looks so much like it's a choice. This person chose to do this, and so if you don't look much further, it looks very much like a choice. And then so what's wrong with this individual that they're choosing? Sometimes their drug use over their children or things that would seem like they're so foundational. But I think that's the humbling thing as I've worked with substance use disorders, is just that recognition that our very humanness makes us vulnerable to this disorder. I'm what they call in the mutual support self-help groups a normie. I'm somebody who never used drugs and alcohol, which is kind of weird for somebody in my generation because everybody was doing drugs and alcohol. But I went the religion route instead. That was my drug of choice. And so, what is kind of hard to understand sometimes is that I firmly believe that every single solitary one of us is vulnerable to an addiction just by virtue of the way our brains are structured and organized. And we just, haven't found the substance or the behavior that would addict us, I would assume. And, but it's so easy. And we, like your vignettes again pointed out, no one's immune from this. I mean, people that are active in the church or people that are physicians, we probably both know physicians who've been actively using, who you'd think would know better, and yet what's going on? I used to, for a while, I did assessments for the California Nursing Board and a couple of other licensing boards, and I would, assess these people who had diverted medications as part of their job, and all of them were wonderful people, talented people, highly educated people, and yet had gotten into serious trouble because their addictions had driven them to do something that they would have thought they would have never ever done in a million years. And yet here they were, and their license was in jeopardy, and their livelihood was in jeopardy. I mean, it was, and again, it's clear that was not a choice. Something was compelling them to do that because their brains had been profoundly changed. And so I think I'm a firm believer that the disease perspective takes away that stigma, because I could have that disease too. It's just, and maybe by virtue of my genetics, I'm more predisposed because I happen to have discovered that I'm 67% Irish or something like that. And there's that stigma or a stereotype about Irish people. But, I don't know. I think it's there. I think we all as humans inherit this capacity to become addicted. And so, and that disease becomes potentiated then when we engage in these behaviors. And some of us are just fortunate enough that we didn't engage in these behaviors for some bizarre reason.
So we have all of these tools, right? We have stages of change theory. We have motivational interviewing. We have now the disease model of addiction. And yet, and this, this study of addiction in clinical settings, in academic setting, has been going on for quite some time, right? Yet it still seems so intractable in these contexts. So maybe you can speak a little bit more about that intractability. As I was reviewing literature, I was looking through some qualitative studies, among which are many studies done to investigate why patients who have a substance use disorder may be checking out of the hospital against medical advice. And some of the quotes that I I see in the literature seems very striking. I mean, it's not surprising, right? But some of the example is that, a patient who was poked by a needle says, ouch. And the clinician says, oh, needle hurts, don't you do it for fun? Another example is patient coming in sick, and the clinician's response is, oh, I'm so sorry you're so sick. Isn't it your fault? Right? So why is, given all of these tools that we have now in our toolbox, why is it still so intractable?
You mean the stigma part?
The stigma part of it, yeah.
Well, I think two things come to mind. One is just that, as with most stigmas, we don't see it until we look at it in ourselves. And the clinicians who made those side comments may have never really examined, what their attitude is and the effect it has. So that, I think, is part of it. I think it's also that the community of physicians, for instance, emergency room physicians, may not have really been as culturally engaged in exactly this kind of discussion, even though they see a lot of people with substance use disorders. And so it's still culturally appropriate to kind of make those comments, just like, how certain things were culturally appropriate 50 years ago that we won't tolerate anymore. So I think some of that is part of it. The other thing is that the real cure for stigma is listening, is really listening to people with the disease who are trying hard, who are going through it. And you as with any stigma, the more time you spend with the stigmatized population, the more your stigma diminishes, actually. And you see just how very, very much more human they are than they are an addict.
Yeah. I would wonder if that's a great question. I would wonder if part of it, we were talking before the webinar started, or before this meeting started, about maybe then also social contexts. And you're kind of you're talking about that when you talk about culture, that we live in a society that still demonizes people with substance use disorders. I haven't heard recent statistics, but I know at one time I heard a statistic that something like 70% of the incarcerated population is there because of substance use issues. And, can we imagine what would happen if we locked up all the people with diabetes or high blood pressure or heart conditions? And we would never do that. But we exist within a society that wants to punish people with substance use disorders. And I think that's part of what keeps it going. So how does a healthcare professional who's existing within the context of this larger society that wants to punish, how do we have an enlightened attitude? And then I don't know about you, Dr. Christison, but sometimes when we talk about our attitudes, our professional attitudes, maybe in our own social contexts, we get pushback from our peers, our non-healthcare related peers. Like, how can you think that? It's just a choice. And if they really wanted to change, they would do better. So, we have to, in a sense, kind of be strong, I guess, within ourselves, in a sense, in our own contexts, because we're getting pushback from a larger society that doesn't see it necessarily this way. At least here in the United States. My understanding is maybe abroad there's some more enlightened ideas, but here in the United States, it's a pretty much punishment kind of mentality, I think, that a lot of people take toward this issue.
So as we continue the conversation on the stigma, I think it's safe to say that it's well established that stigmatizing attitude has a negative impact on patients, right? That patients tend to maybe you will stop seeking treatment, right? Not wanting to come back to the healthcare context again. Or it could cause interruptions in their treatment, or people who have relapsed or were in treatment before because of a negative encounter with a healthcare professional may not return as a result of that. Right? So I think it's well established that there are negative impacts on patients' outcome. But based on going back to earlier discussion of the clinical vignette, it's also extremely difficult for healthcare professionals to work with people who are struggling with substance use disorders. And so one of the things that I learned about from speaking to the two of you is caregiver stigma, right? That people who are actively caring for people who perhaps have the most day-to-day encounters with people who have substance use disorder can over time begin to take on stigmatizing attitudes. And I would be interested to hear you talk about that a little bit. What is caregiver stigma, and how do clinicians take on those thoughts and attitudes over time?
So you're talking about us as professionals. How do we develop this? I think, for myself, because I've dealt with some of that stigma sometimes. I think it's been a little bit harder for me, only because my first exposure to working with substance use disorders exclusively was in a setting that was very research-based, and a lot of the treatment was being informed from the idea that we do anything to try to engage and retain this person in treatment. So it was hard in that setting, maybe to stigmatize, or that wasn't supported in that setting. But I know one of the things that started to contribute and to be honest, I burned out in that setting. And part of the reason I burned out, I think partly was because I was taking a lot of responsibility for the treatment outcome, and feeling like if somehow this person relapsed, or if they didn't stay in treatment long enough, or that we didn't get they didn't get to the end of the treatment episode and be totally abstinent, then somehow it was my fault. I was an incompetent clinician. And I think that contributes to the part of the stigma. I think another part is then when I left that setting, after I burned out and I kind of recovered, I recovered from burnout. Then I got to, thank you. I consulted for a while in a residential treatment program that was primarily paraprofessional. So I was the one professional among paraprofessionals. And there's something very kind of stress reducing and stress relieving to sit around and make fun of people with substance use disorders, because just like you were relating in your vignettes, they do the craziest stuff, and it's kind of funny on some level that it wasn't so tragic and scary, and it's easy to sit around and make fun at their expense, and that I think contributes to the stigma. It's not intentional. We would maybe never ever say that directly to the client, or the patient, but yet that's, I think, what a lot of us sometimes, how would we cope from this really stressful position of having these very demanding patients that do really scary things, and who are out of control, and we don't feel particularly in control in perhaps helping them.
Right. Yeah, I think all of those things, and many of the people who are really the frontline people, the rehab counselors, and who are doing in a residential program, for instance, doing the groups, doing the individual counseling, and they bring two things to the table. One is their past history of before they got into that job. Many of them are in recovery themselves, and so they get it. They I think really make some of the best rehab counselors. But others just, were looking for a job, and they got this job, they got licensing, and what was in their family background, what was in their cultural background, regarding this, they bring to that. The other thing, though, is what you were talking about is now their experience with this population, and which again brings up a lot of sense of inadequacy because, maybe 20% or so are leaving AMA and you don't know, or this person's coming back for the 5th time, is this really going to work? And also, sometimes, people in recovery aren't the nicest people, and they may be saying stuff back, or even testing to see if you're going to still hang in there with me. So I think that then can contribute to the development of caregiver stigma. And I think another really big thing, and this is a tough one, is the culture of the house. Where the program is and what the people at the top are saying, this is acceptable, this is not acceptable, and are modeling the kind of approach that says, some people aren't going to make it, but we're going to hang in there for those who can. I used to tell my staff, even if you have to use denial, keep hoping, keep believing in this person. And you have to have that rather than moving into bitterness and cynicism.
One of the things that I learned working with Matrix Institute was they were really clear, encouraging us to recognize that people in treatment live longer than people who are not in treatment. So even if people aren't doing well, so they're somehow having contact with the treatment facility, they're maybe still using, they're not abstinent, but the chances are that that person will live longer than the person who's out on the street just using. And I think in my experiences, that's true, but that's hard to deal with, because how do I work with somebody who in a sense is coming to me to stop this behavior, but they're still engaging in the behavior, and I'm able to stay with them and not see myself or them as a failure, but I'm actually making a significant contribution to their longevity just by retaining them in treatment. And funders don't necessarily like that sometimes, because they want hard outcomes, and you're not able to say that. You're able to say, okay, well, this person went from using every day to now they're only using twice a week. That's a huge change, but the funder doesn't want to pay for that. They want 100%. They want no use. And I don't mean to criticize funders, but that's kind of the reality that, especially in nonprofit settings, that, we deal with sometimes, I think.
So both of you have already started to talk about that. So maybe it's time to switch gears a little bit to talk about what we can do to reduce some of these negative reactions. And you've already touched on, the idea of hope, the leveraging the therapeutic relationship, that if you maintain that relationship, it's even if the patient is not progressing as we hope, right? There is some benefits to that, even if it's not immediately obvious to us, right? So as both of you have alluded to, it could be extremely stressful, emotionally taxing. So how does one cope with that kind of situation as a healthcare professional? Right? How do you deal with that?
I think for me, I can say really without a doubt that in the 40 years since I graduated med school, I was 12. The biggest change that I've seen clinically is with some of the people who entered rehab at the absolute bottom. They had no family left. They had, really burned every single bridge and then gone back and burned them again. And then this is what the last vignette was. A year later, they're a different person. Their personality is different because they're not on the substances anymore. They're beginning to believe in themselves and that is the hugest change that I've seen in any clinical kind of setting, and it can be maintained. And so I think that part of what seeing people in successful recovery, then when you see somebody who's not yet, or maybe even showing up for the first time and is lying to you in your first appointment, keeping in the back of your mind the picture of the guy that was successful and that this person could be the next one. And that to me really helps to hang in there with this guy, because I know a guy who is just like that, who's so much better right now. So I can have hope for this one.
I think one of the things that's kind of helped me find some hope in all of this is, and I think it's interesting in this context of Loma Linda University and a religious institution. I resisted for a long time when Matrix initially, way back when, started becoming more friendly or more accepting of 12-step involvement. Because Matrix, which was founded in the early 1980s in response to the cocaine epidemic that was going on at the time, and they were seeing themselves as an alternative initially to self-help kinds of groups. But one of the things that I've recognized as a result of then being exposed to a lot of self-help 12-step material over the years is the sense that, okay, so do I see myself as a professional cooperating with a power greater than myself? And that, it's not just me working with this client or this patient, but there's something bigger than me that's working with this patient too. And can I get out of the way and let, that power greater than myself do something in this person's life? And sometimes it could be that, okay, so I'm going to be present, I'm going to do the best I can. But I can also sometimes, maybe I have to let go. And that's the hard part. And that somehow that then is between that patient and that power, whatever you call that power, God or whatever. To me, that's been something that's been really helpful. It's hard to do, and I've tried to encourage family members to do that too. But it's, but I think that's kind of, I think, how I'm getting some hope in all of this.
Another thing I want to mention along with that is to have a mindset that, I really like talking to people who just relapsed, but who made it back to my office.
Yeah.
Because, it's a time for them to see, number one, that I'm not rejecting them, that okay, it happened. But number two, to really reframe it for what it is in such an incredible learning time. Okay, so what happened? What would you do different? Let's look at it, let's learn. And because they feel such shame and self-blame. And so to be able to yourself as a clinician reframe it as, this is a great chance right now because they just used yesterday, instead of like, oh, they just used yesterday. But how can we use this to reinforce that I'm accepting and that we can learn? And that's a real powerful message.
Well, and I would kind of throw in there too, then what you're in that reframe, I really like your use of the word reframe, that there's a strength, an implied strength that I think sometimes we don't recognize. So how did this client have the strength to show up? And we forget that sometimes. Okay, so how do you keep coming to treatment even though it's not working? It doesn't appear to be working the way that you wanted it to. And that's a huge strength. And yet so often we look at the defects in the patients as opposed to the strengths that are they're presenting to us.
So we're getting close to the end of our conversation today, so I would like to, at this point, invite our audience participation. I'm seeing that people have already started to submit questions in the Q&A box through Zoom. So I want to invite anyone here who is here in person. If you have a question or like to make a comment, please raise your hand, and one of us will be running up the mic to you. So the first question, what are some ways that clinicians can stay in the patient-clinician relationship when it can be so emotionally taxing in order to do so? Also, in some situations, a clinician's license may be affected by how one treats patients with substance use disorder.
I'll speak to the taxing part. Because I think in general, if you follow guidelines and respect boundaries, your license should not be really at risk. But the taxing part, I think you really do have to watch your own, to what degree you're trying to put on a cape and be the hero. And instead of simply being a co-traveler on the road, because you can't save them. You can be there and help and provide ideas and structure and acceptance, but it really is their recovery. And particularly if you're working harder than your client or your patient is, then that's a recipe for discouragement and burnout. But even when you're doing everything right, if you have a significant caseload of people who are, seriously into substance use disorders, I think you really have to monitor your own sense of compassion fatigue and maybe begin to move to lower the fraction of your caseload that has that, or to talk about it more with colleagues, or to really begin to look at making changes to help you hang in there. There's a variety of things you could do, but it often happens, and you have to kind of look at it. And so looking at yourself is the first real big step.
I would maybe add to that that I think also doing continuing ed or continuing education and being very selective about continuing education can be really important. I know for me, it's been always so motivating to go to conferences where there's addiction is a brain disease kinds of perspective, and you hear about new medications or new research that's coming out, and there's a lot of hope because we're in a much different place today than we were 30 years ago, and we understand the brain a lot. Even though we don't understand it fully, we understand it a lot better today than we did 30 years ago. And I think that has a direct impact on the efficacy of treatment. And staying up on some of that, I think, is really very, very important as a professional.
The second question has to do with the disease model. It says, while ongoing addiction is a disease, it has both physiologic and psychological components. The initial choice to use a substance to which the patient becomes addicted carries elements and nuances shared by other choices relating to the development of disease, such as risk tolerance, noting the one masked and the one unmasked panelists, right, today, for example. The main significance of the distinction between a choice and a disease is that responsibility is commonly assigned to the former, but not the latter. So is it useful to have clinicians view the patient as having made a choice which they may have responsibilities for, right, such as economic consequences, but then developing a disease which they don't have responsibility for?
I would really take issue with both arms of that. The first use, at least when you're working with a public sector population, the first use is almost always in their teens, and early teens often. And so the degree to which I'm going to hit them hard with, well, that was your fault because all of your peers were doing it and you were insecure as a 13-year-old and you used for the first time. I have a problem with weighting that with significant responsibility. On the other hand, I do not see the disease model as abrogating responsibility any more than someone with diabetes does not have the responsibility to care for their diabetes because they have a medical condition. That doesn't make any sense. So they have a medical condition of substance use. It is their responsibility, yes, to deal with that as best they can. And also, we're asking them to keep coming back, when you feel, I don't know what your record is for number of times in rehab before it finally clicked, but I've seen 7+, times. And also with opioid use, I'm going to segue here, I'm sorry, but opioid use disorder, 6 months is a victory. 12 months is incredible. And so particularly with that disorder, sort of redefining what recovery is. It doesn't mean never use it, but it means keeping coming back because it's such a tough drug. So no, they have responsibility with the disease model. But I, would have to really caution to look carefully at all of the factors that were culturally, socially, and developmentally present in that first use.
Yeah, I think what I would maybe add or emphasize in that is that, I think we all imagine choice to be some sort of same experience across the board, and that, we don't all make the same choice. I think about the life that I've had. I grew up, and I've said this to students over the years, I grew up in Leave It to Beaver world. I've gotten to the point in my life where lots of people don't know what Leave It to Beaver was, but for those that do know who Leave It to Beaver was, I grew up in this charmed childhood where it was a much different world than it is today. And the choices that I got faced with as an early teen, when I kind of encountered people that were doing drugs and alcohol, those were very different choices than if I had grown up in an environment that was maybe an impoverished environment, or where I was dealing with lots of crime, or a liquor store on every corner, or I had been traumatized. I think, we want to say that it's all the same choice, that the choice that this guy got to make, and he successfully made the choice, how come you can't make that choice? And I don't think that's fair. I think they're different, very, very, very different choices.
So we're getting to the end of our hour here. I just wanted to ask if Dr. Christison and Mr. Walker, if there's anything you would like to add before we close the conversation today.
Yeah, I think there's an elephant in the room that we haven't talked about, and that is the exploding number of opioid deaths. I remember 10 years ago when I was stunned to learn that there were more opiate overdose deaths than deaths to motor vehicles, which is around 50,000 a year. Now it's over 100,000 a year dying from opioid overdoses, whether they are intentional or probably mostly unintentional. And so the notion that getting involved with helping people with substance use disorder is in fact life-saving and very much needed, needs to be emphasized. We need more people who want to help these people, and to begin to try to turn around what has happened in the last 10 years, 10, 15 years with the overdose situation, which is a tragedy beyond words, really.
And echoing that, I think what I would say is that I think a lot of us sometimes imagine we can go through our professional lives without ever encountering people with substance use disorders, and that's a myth. The reality is those people are there, we just don't see them. And can we develop the skills to be able to give these people help in an effective way, in a gentle way, is really critical, because I think the idea that we could practice and never encounter individuals with substance use disorders is a fallacy.
Thank you so much to the both of you for wonderful, excellent, informative conversation today. I would invite the audience to join me in thanking Dr. Christison and Mr. Walker. Thank you so much for joining us for today's Bioethics Grand Round.
Very good.
Oh, you're welcome.